Thank you for the invite. Oh, there you are. Thank you for the invite, Dr. Gilada. One of the great things about when you're invited to this is you're asked what you'd like to speak on. And I gave 4 possible topics, and I always get asked to speak on something different. But anyhow, I don't want to go over what's been said before, because I also got sent a very similar slide set. And so I think I'm going to use this as a general talk about comorbidities you get as you get older, and also just touch on TAF. Now, given I'm a fair old age now, little did I know when I saw my first patient in '82, which is around 35 years ago, that what we had then, when everybody was presenting with opportunistic infections, and their average life expectancy in those early days pre-AZT was around a year, that we would have the situation we have now, where patients can live a pretty normal lifespan. And what we're dealing with is the comorbidities of aging in the heart, the kidneys, the liver, the brain, and this is what we spend our time being concerned about. And of course, about half the patients who come and sit opposite the desk in the consultation room that see me are now over 50, and a considerable portion are actually older than me. And also, it's difficult to believe that, that early time when AZT came along, and I remember the AZT rep coming to see me, that we would have the drug then that very quickly realized that resistance was just occurred very easily because it was a very promiscuous virus in its reverse transcriptase activity, to the situation we have now with the drugs that even with the person with the most multi-resistant virus, we can get their viral load undetectable as long as they take their drugs. So it's that incredible situation from having one drug where you always saw resistance to giving a combination of drugs now that are highly active even against very resistant virus. If one picture can tell 1,000 words, then for me, this is the picture. And this is America, it's young people, and it's the way that the death rate from AIDS climbed through all the other mortality rates to become the top killing disease in patients who are aged 25 to 45, or young adults who are aged 25 to 45 in the USA. And the impact of heart can be equally shown, and how quickly this death rate came down as a result of drugs. And this is one of those times in life where I was there, and I remember that Vancouver conference, and I remember how exciting the data was. So many conferences you go to now, and really there's not very much. But that Vancouver conference was a real milestone, and at the same time, of course, you got viral load estimation. And we all know that the drugs then caused a lot of problems, especially with cosmetic from the thymidine toxicity and Crick's belly, which was indinavir belly or protease belly from the protease inhibitors. Now treatments are so much easier. We just have a combination tablet. There are now 5 single tablet regimens that you can give. And so adherence is much improved from that. And all we've got here in this slide, on the left-hand side, we've got the age of patients who present now with HIV, and you can see the number of people who are getting older and older is increasing, and the number of diagnoses that are younger, and then patients who are seen in clinic is getting less frequent because so many patients are living longer on their heart. And now the life expectancy for someone who's HIV positive where they don't inject drugs, they don't have a lifestyle which puts them at risk of comorbidities such as recreational drugs. They're not hepatitis C positive, and they take their drugs there. Their life expectancy is pretty much the same as someone who is HIV negative. And they looked at that data using the SMART and the ESPRI studies. And what they showed is if you had a viral load that was undetectable and a CD4 count that was over 500, then your life expectancy was, using mathematical modeling, was equal to that of a person who is HIV negative. So if somebody takes their medication and achieves a high CD4 count, and you're more likely to do that if you start treatment earlier, then your lifespan should be normal. I'll just leave that out. And this is something we all know when it comes to dealing and preventing the comorbidities that we see so often now in our patients, is implementing the known interventional techniques we have to hand. And that, say, this is the DAD data, on top of which somebody has put what happens if you stop somebody smoking, what happens if you control their blood pressure and control their lipids. And you can see how you can produce a significant decrease in the incidence of a cardiovascular event. So here we go on to what I'm meant to be talking about, which is the comorbidities in HIV. So looking at a lot of studies, and this is a meta-analysis looking at studies, even where everything is controlled for, smoking, blood pressure, cholesterol, the drugs a patient is taking, the antiretroviral agents a patient is taking, you still see that patients with HIV have around a 1.5 times increased rate of having a cardiovascular event compared to somebody who's HIV negative. If you take patients and look at their renal comorbidities, somebody who has HIV is 3 times more likely to have chronic kidney disease when it's untreated HIV than somebody without HIV. And where you have somebody being treated for their HIV successfully and compare it to somebody who's not being treated, then again you are 3 times more likely to have chronic kidney disease. So treating somebody with HIV effectively is going to reduce the incidence of chronic kidney disease. So you have that impact on kidneys as well as you do on heart. And the same is true on bone. Systematic analysis have looked at the incidence of osteoporosis and the incidence of bone fracture, and they are increased in patients with HIV compared to those without HIV, again, irrespective of whether they're taking HIV treatment and matched in every other way. What about the impact of drugs? Now, a lot of people have made up their minds about the abacavir story, but there is no doubt that many of the cohort analyses have shown that if you take abacavir recently, you are more likely to have a myocardial infarction, whereas the cumulative effect of abacavir is nowhere near so significant. Now, although there have been other cohort analyses apart from DAD which have supported that, there have also been cohort analyses which have refuted it. And so one can always say that the jury is out, but there is no question that some cohort studies have shown that if you have a high risk of cardiovascular disease already, then you increase that risk even more if somebody receives abacavir. But we're all using abacavir in clinical practice, and I think with the advent of Triamec, with dolutegravir and Carvexa, I think the use of abacavir has gone up considerably. The same, we're concerned, all of us, when we're practicing, we're concerned about tenofovir and renal toxicity. And we all look at patients, we've been following them up for years, and you can see that eGFR is falling slightly, their protein creatinine ratio is increasing slightly, and we have this sort of impression it is tenofovir, but they're aging, they may have developed hypertension and diabetes, and it's quite difficult to tease out what is in fact related to the drug and what is just the comorbidity that the patient is suffering from. But again, many studies have shown that tenofovir is associated with osteoporosis and is associated with an increased risk of bone fracture. What about kidneys? Now again, there's a concern that you see, and I know the sort of talk I was giving to the slide, they were the wrong way around, and that was to the renal and the dropping GFR, but the same is true for the kidneys. And you can see here that with time, this is a Eurocedar study, and they defined people in a slightly complicated way in that patients who started with a GFR that was above 60 on 2 occasions, and if it dropped to below 60, then that was evidence that the patient was developing chronic kidney disease or had progressed. or if the patient had a GFR below 60 when they started this cohort analysis, and it dropped by 25%. That defined progressive chronic kidney disease. And what you see here at the bottom on the right is you can see that tenofovir, there was a significant association between taking tenofovir and progression of your renal disease. So for the drugs, the obvious implications we've all known about: kidneys and bone with relation to tenofovir, and heart with relation to abacavir. And when you look at overall at again a study comparing HIV negative and HIV positive patients, and look at the comorbidities that you see in those patient groups, and this study from Italy looked at 5 particular comorbidities: heart, hypertension, diabetes, type 2 diabetes, that is, and osteoporosis. On the left-hand side, you've got the HIV positive, and on the right, the HIV negative. And blue is where you have no age-related comorbidity, and you can see how many more patients in the HIV positive greater than 60 year histogram bar have comorbidities than they do in those that are HIV negative. You can see only a small percentage have no comorbidities aged over 60 years of age, whereas over half do in the HIV negative. So let's move on now to TAF, which again was something I was asked to talk about. Tenofovir, the problem with tenofovir is that once it's absorbed, it gets into the plasma, and in the plasma it's at a high level, and then it gets into the target cell, and then it has an action against HIV. Now, tenofovir alafenamide, TAF, goes into the plasma, and in the plasma it doesn't get converted to tenofovir, or very little, and then that gets into the cell, and then it's converted to tenofovir. So the levels that you have in the bloodstream are much less. And so in this slide, looking at the top part of it, you have with TAF, and this is in the form of Genvoya, with elvitegravir, cobicistat, and I've forgotten which drug it is, emtricitabine. Then you have, with patients with an eGFR of 30 to 59. So these are patients with diminished renal function and defined as having chronic kidney disease. You can see the TAF level there, or the tenofovir level in the plasma, is 670. And you compare that in situations with patients with normal renal function who receive tenofovir, and you can see how they're about 4 or 5 times more. So you take a population who are receiving TAF, who have diminished renal function, and still their level of plasma tenofovir is about a quarter of that with patients with normal renal function who are receiving other combinations. So the studies have been gone through by Dr. Gilada, and I'm not going to go through them again. Suffice it to say that there are 3 studies which are proper blinded control studies, and then you have the switch study looking at patients who've got renal compromise, and they have a GFR which is between 30 to 69, and the patients are switched to Genvoya, which is elvitegravir, cobicistat, TAF, and FTC. So 104-111 is Stribal against Genvoya, and I know you may know them as different names here, but one is elvitegravir with TAF, the other is elvitegravir with tenofovir. Then you have the switch, and patients on a third agent being switched to Genvoya with TAF or continuing on their other regimens. And with all these 3 studies, you can see there's no difference in the viral efficacy. They're all highly effective studies when you're comparing Genvoya to Stribal, or you're looking at a TAF-based regimen in Genvoya. They're equally effective. And you've seen this before. It's more protective on the kidneys. It's more protective on the bone, so you don't get the degree of bone loss that you see with tenofovir. So that's summarizing what's already been said. A higher GFR is seen, less proteinuria, and no cases of proximal renal tubulopathy or Fanconi had been reported, although there have now been a couple of cases. The study design 112, I've gone over my time, so I'm coming to my end, was the one where, and you've seen this slide before, patients with existing impaired renal function were switched. And the one thing that can be said, it's not that the GFR improved, it's that the protein loss in the urine and the tubular markers improved. So what are you going to do? How are you going to choose between these backbones? All of them have single tablet regimens. This is Carvexa, tenofovir, and TAF. Patients with high cardiovascular risk, you're not going to give them abacavir. Patients with high viral load, you would only give them abacavir if it's with dolutegravir. Obviously, if they're HLA-B57 positive, you're not going to give it there. If they have osteopenia or osteoporosis, you wouldn't give tenofovir, but you can give TAF. I've moved on quickly there. And if the patient has renal impairment, then you're not going to use tenofovir. You can use abacavir and 3TC, but a reduced dose of 3TC. So the question I ask to you in the audience and to the panel is, are you looking at using TAF with FTC, which is Descovy, in all patients who are on Truvada at the moment, just switching them over? Are you going to leave it? Are you only going to do it in patients with established chronic kidney disease or osteoporosis? Or are you looking at patients with the potential for chronic kidney disease, like older patients and who have maybe osteopenia at the moment, do not have established osteoporosis? So I'll finish there just to say that for the UK, this is what we face, the cost of drugs, given that it's about £500 million every year that we're spending on our drugs. Thank you very much.
Thank you, Wilkins. It's a very fine and what we call it as a razor shave presentation. Please come.